So welcome to this evening's teaching session on wet AMD on OCT, and that's obviously being given by our fantastic Mr. Mohamed, who's going to talk us through that. He is, where should I start?
Don't
Obviously,
bother.
our,
I'm a consultant at St Thomas's. That's all you need to say.
there we go. Consultant Thompson. But that's the tip of the iceberg for what you do for us. Obviously, there's all the teaching support that you give, all the auditing support you give, not just here, but also in Tanzania as well, and also a College of Ophthalmologist examiner. Oh gosh, your research base. Oh goodness, I could go on. Let's
Uh,
stop.
let's
Let's
talk
stop.
about OC. Let's talk about OCTs.
Yeah. Let's talk about OCTs. I'm going to ask all our participants to please do interact. If you have questions, do ask questions. You can type it in the chat if you're more comfortable, or Mr. Mohammed is quite happy for you to interrupt. We are going to talk for a while. At the end of the session, we'll have a more active Q&A session. So thank you, Mr. Mohammed. Over to you.
Yeah. So, the primary purpose of these talks, when I originally chatted to Bavina about it, is really about improving OCT interpretation skills. So the focus very much is on OCT interpretation rather than general medical retina learning. But we're very happy to do that. Just give us feedback, and then we can tailor things in the future accordingly. But really, we just wanted to try and just improve everyone's OCT interpretation skills. So last time we went through the very basics of OCT interpretation. So we'll look at that. It can be very difficult, and we see that in hospital practice all the time, that misdiagnoses happen, patients don't respond, and then you look again and it might be something else. So there's sort of no shame in getting the diagnosis wrong, because when it's barn door obvious, everyone can get it. But when it's a bit more challenging, then of course it's difficult. So last time we sort of mentioned this international nomenclature. So if you want to know the absolute accepted international terminology, this is the paper to read. It defines every single layer on the OCT scan. So we went through this last time in huge detail. And then OCT scans, you can do these average scans if you get some more detail. And I think Bavina's going to show a case at the end, which has got a beautiful average scan, which gives you just so much more detail. And then we do EDI scans. So particularly when looking at AMD or wet AMD, an EDI scan, an enhanced depth image scan, and all your scanners will have that setting, gives you much better and better defined outer retinal detail and choroidal detail, which becomes important. And then we sort of introduce this concept that if you're completely stuck on an OCT, then go through this 1, 2, 3, 4, or 1, 1, 2, 3, 4, 5 approach. And what we meant by that, if none of you were on the talk last time, we'll just run through it very, very quickly, is 1, look at the foveal contour. Is it smooth? Of course, if it's not smooth, is it elevated? Is it elevated for a reason like leakage or exudation? So of course, when patients with wet macular degeneration are symptomatic, more often than not, something is involving the fovea. So that's a good starting point to see if something's going on. The second thing we do is look at the nerve fiber layer. Then we really want to look at the structural integrity of the neural retina. So that plexiform layer should be in continuity across the scan. And then the nucleated layers should all be there. And this is super, super important for AMD because when, again, particularly looking at dry macular degeneration, we're doing it in a slightly topsy-turvy way this time. We're doing wet macular degeneration first. And that's important because that's the thing we can treat, and it's rapidly sight-threatening without intervention. So we look at the nucleated layers, and things like dry macular degeneration, all the new classifications really relate to what the nucleated layer, particularly the outer nuclear layer, the photoreceptor nuclei, and what the outer retinal bands are doing. So we're really grading all the newer for interventions for geographic atrophy. We're absolutely looking at what the pigment epithelium looks like, what the ellipsoid line looks like. So so we've got 3 nucleated layers. We've got 4 outer retinal bands, which is the ellipsoid line, the external limiting membrane, which is where Muller cells end, the ellipsoid line, which is the mitochondria in the photoreceptors, the interdigitation, which is the photoreceptor outer segment tips, and the pigment epithelium. So the pigment epithelium is absolutely key structure in macular degeneration, how we define macular degeneration, really revolves around how the pigment epithelium appears on slit lamp by microscopy. So the choroid is important in macular degeneration as well, because more often than not, the choroid is thinner in elderly patients. And there's 5 layers in the choroid, from Brooks membrane, and then choroid capillaris, Sattler's layer, Haller's layer, and then the sclerochoroidal interface, which again, for some of the newer anti-VEGF agents, which are being, if some of you have done any reading about the newer agents which are being introduced, these sort of do once and treat gene therapies, they're going to be introduced into the suprachoroidal space. So suddenly this thing which we've completely ignored for years is now going to be absolutely key for drug delivery. So we sort of said last time, we're looking really, is there an abnormality of shape, which is a sort of overall global type thing, which we see in myopia, etc., or is it an abnormality of structure? And that abnormality of structure we'll try and define, is it pre-retinal, epiretinal, intraretinal, subretinal, sub-RP, so an anatomical localization. And then you've got to try and decide, is there extra tissue or missing tissue? And we decide that based just on the reflectivity characteristics. And you decide it's missing tissue just because that banded architecture is disrupted, or extra tissue if something is disrupting and forcing those layers apart. And then just the reflectivity characteristics. So we all know fluid is black. So things like vitreous, aqueous, silicon oil all appears black. Scarring, scar tissue, exudate all appears very, very white. So looking at the reflectivity characteristics, we can make some sort of educated guess as to what that tissue or change on the scan may represent. So today, the primary focus, Bhavina asked me to talk about wet macular degeneration and how to identify that. Of course, the difficulty is if it's banned or obvious, then it's banned or obvious, and everything starts early. So sometimes just very, very subtle changes, more often than not, we'll bring those patients back in a couple of weeks' time and repeat the scan, see which way it's evolving, whether it just spontaneously disappears, sometimes that happens, or whether it is truly progressive. So the first thing to note in the medical literature, the term for choroidal neovascularization, which we've all been used to. I mean, when I started, it was all subretinal neovascular membranes, SRNVMs, and then it became CNV. But now the preferred term is macular neovascularization. And there's a reason for that, because not all wet AMD originates in the choroid. Some, we'll come on to this in a minute, originates in the retina. So it makes far more sense calling it the sort of more generic macular neovascularization, which covers all those. And then one of the points I think Bhavina asked me to cover was, what are the red flags? Well, it's very difficult because macular degeneration, when it's dry, really has just dysfunction, and patients can still, their Snellen acuity is still pretty good. Now, vision starts changing when, of course, the retinal structure starts changing. So if light isn't falling on a planar surface, on a flat retina, then of course patients are going to start getting distortion. And that's a key symptom. But not everyone can describe that. And it's just amazing how often in a wet macular degeneration clinic, people, especially with left eyes, non-dominant eyes, the brain is fantastic at just ignoring symptoms. So the characteristic changes in wet macular degeneration are serous detachments of the neurosensory retina, so that's subretinal fluid, intraretinal fluid, and that really tells you the blood-retinal barrier has been disrupted, and then subretinal or sub-RPE fibrovascular proliferation. So fibrosis and vascularization go hand in hand. And this is pathological. So this little diagram is there to remind us that there's 2 processes. Vasculogenesis is the normal development of normal blood vessels, which happens as an embryo and in the first few months of life as the peripheral retina gets vascularized. Angiogenesis is always pathological. So the network of blood vessels is very ordered in vasculogenesis and smooth and straight and fractal, whereas it's much more disordered and incompetent. So incompetent vessels leak and bleed. And what do they leak? Well, they leak serum and protein, so that's exudate, lipid, fats, and serous fluid, which is what all translates to subretinal fluid, intraretinal fluid. And then eventually, and we don't see this very often, hemorrhage, unless there's polypoidal vasculopathy or so, and even hard exudate usually means leakage has been going on for a very, very long time. And the thing we don't want to see is subretinal fibrosis, because that tells us it's sort of game over. So going back to last time's, we'll start off with a quiz. So we'll go through 5 cases. So I'll just give you, say, 10, 20 seconds on each one. Just have a little look and see what you think these cases are. So have a look at this one. In your mind, I'm not going to, unless anyone really wants to volunteer and say, I think it's this or that. Bavina's smiling, maybe she wants to. I don't know. Do you want to? No? Okay, well, okay, that's enough time for the first one. Here's the second one. So we are talking about wet macular degeneration. So, you know, that's a big clue as to what's going on in these cases. So just think, what diagnosis would you give to these cases? Okay, we all had enough time to have just eyeball of case number 2. Here's case number 3. So again, have a look at the layers. So, you know, first thing we said was look at the foveal profile. There should be a nice smooth dip. Of course, it's elevated here. Is there extra tissue, missing tissue? Well, there's something extra going on there. A little bit of disruption, widespread. Another case here. And last one here. Okay, so the similarity, all of those cases have got outer retinal disruption, they've all got subretinal fluid. So every single one of those suggests there's some sort of exudation. So here's the cheery news. Did anyone think all of those were wet macular degeneration? Because not a single one was. They're all masquerade syndromes. So, and these are all cases which have been in our clinic who have been referred with either wet macular degeneration or some sort of neovascularization, but none of them actually are wet macular degeneration. So for this talk, really what we've got to talk about and think about is how does wet macular degeneration happen? So we have to mention dry macular degeneration if you talk about wet macular degeneration, because wet macular degeneration is the consequence of the process of dry. And then there's a whole bunch of masquerade syndromes which we'll sort of try and rattle through. So in terms of the basics of dry macular degeneration, the international classification says, well, you've got to have drusen and pigmentary irregularities in an individual who's over the age of 55. So if they're younger than 55, they by definition can't have wet macular degeneration. It's got to be some other early onset drusen disorder. And of course, those drusen have got to be within 2 disc diameters of the center of the macula, or the macula essentially. The clinical macula is a 2 disc diameter circle centered on the fovea. So that's the absolute bare bones of it. So always think, is this patient old? Are there pigmentary irregularities? Are there drusen? So the best natural history study was the ARMD study, which many of you would be familiar with. And it really is a good classification system. So I've got a picture of a disc here. And the reason for that disc is a sort of standard given is the vein as it crosses the disc margin is 125 microns. So 125 microns is obviously, it's not always going to be the case, but as a sort of rough, crude measure, it's fairly accurate. And so the vein crossing the disc is about 125 microns. So you've immediately got a reference point. So the ARMD classification is 0, 1, 2, 3, 4, and it's no aging changes, normal aging changes. That's a real gray area and a little bit of a cop-out. Early AMD, intermediate AMD, and late AMD. And those are defined by drusen being less than 63 microns. So that's less than half the size of the vein as it crosses the disc margin. Medium drusen are somewhere between half the size and the full size of the vein as it crosses the disc, and notably no AMD pigment change. So if you've got any pigmentary irregularity, any foci of hyperpigmentation, then they've got to have intermediate AMD, and it's an independent risk factor, just as significant as large drusen is. And then large drusen, this is where it gets sort of interesting because of the natural history connotations. So if a single solitary druse is bigger than 125 microns, which is the size of the vein of the disc, then that patient has got stage 3 AMD. And stage 3 AMD means they've got a 25% chance of getting wet AMD in the next 5 years. And the AREDS classification in the AREDS study said only patients with stage 3 or stage 4 have any benefits from an AREDS 2 vitamin supplement. And then stage 4 is late or established AMD, where you've got neovascular AMD, or macular neovascularization as we want to call it now, or any form of geographic atrophy. Now, the original classification used to say geographic atrophy at the foveal center, but now it's been reclassified. Any foci of atrophy anywhere is regarded as stage 4, which is sight-threatening disease. So just examples, and of course, I think pretty much all your OCT scanners will have a little caliper. And what I do frequently in clinic, so on the Heidelberg, there's this little L-shaped thing, and it's 200 microns in the vertical, because these scans are stretched for us to pick up detail, whereas 200 microns is short on the horizontal, it's long on the vertical. You can manipulate it to a 1-to-1 ratio, but we pick up much more detail when you elongate the image. So small drusen, as the AREDS classification says, small drusen, stage 1, is normal aging. So we're not entirely comfortable with that because it's not normal, but it's normal aging, but it is degeneration of the macula. Stage 2 is intermediate drusen. So again, you can get your calipers out and measure the base of a single druse. And if it's between 63 and 125 microns, it's intermediate drusen or stage 2. And then large druses are the things you've got to be able to recognize. So you can see here on the bottom here, 200 microns is there. So we can see very easily that that's bigger than 200 microns at the base. So if you see where the drusen are, you can just see Brooks membrane, and you can see the pigment epithelium rises over every single druse. And then in certain points, you can't see the interdigitation very clearly. You can see it here, but where the retina becomes corrugated, it's a bit more difficult to try and work out. But the notable thing is the ellipsoid line gets disrupted and the internal limiting membrane gets disrupted. So we know something quite serious is going on here, and the nucleated layer is going on. So of course, these patients can have visual dysfunction. Their acuity may be perfectly good. They often have 6/6, 20/20 vision, but they will always have visual dysfunction. Mesopic vision goes down, reading speed goes down, changing from light to dark to light, vice versa. It takes much longer, and then when you shine your slit lamp beam, they get macular photostress, and it takes much longer to recover. All these patients say low sunlight, driving at night is increasingly difficult, and that's all the symptoms of dysfunction in macular degeneration. Now, aside from just measuring the size of drusen, we're looking at pigmentary irregularities. So on the Heidelberg, pigment looks white on this infrared reflectance. So you can see there's a lot of pigmentary irregularities. So it's that mottling. You remember that the pigment epithelium is a monolayer of cells with melanosomes, which absorb light, that dark surface. And if you have pigment migration, that is where those pigment epithelial cells have died off, and that pigment is liberated, the melanosomes are liberated and taken up into Muller cells. So we can see at the peak here, and pigment is always very bright white on an OCT scan. So pigment looks like that. At the peak of a chronic druse, you often get focal pigment migration. And the ARED study, the natural history study, said that's just as an important finding as and an independent risk factor for developing neovascular AMD. So it's a really important finding. The other thing which wasn't on the AREDS classification, but we've learned much more about as OCTs have become much more sophisticated, are subretinal drusen or reticular pseudodrusen, as they're also known in the press. So they're pseudodrusen because true drusen are always under the pigment epithelium. But if you see it, the pigment epithelium is pretty flat, and these drusenoid deposits are between the ellipsoid line and the pigment epithelium line. So that corrugation now is in a very different layer. It's in the subretinal space, which is why they're called subretinal drusen. And again, these are a real indicator that patients are much more likely to get either RAP lesions, which is a very aggressive form of neovascularization, or much even more likely to get geographic atrophy or retinal atrophy as a late feature of macular degeneration. And on the infrared reflectance, it's very, very mottled centrally. They're sort of very dot-like. Peripherally, they're sort of more ribbon-like and longer and elongated. But it's a very sort of classic change. And these patients have a lot of visual dysfunction. So their nighttime visual function is really, because you can imagine there's a metabolic block. Photoreceptors get their metabolism from the pigment epithelium. The whole visual cycle happens there. And if you've got basically a layer of gunk which is accumulated in that layer, of course the metabolism is going to be slowed down, and visual processing is going to be compromised. So by definition, a drusenoid, so there's lots of different types of pigment epithelial detachments. It can be solid, it can be serous, it can be fibrovascular, it could be a tumor, but in this context, a drusenoid PD is again another independent risk factor for developing AMD, because these things, developing advanced late geographic atrophy, these things enlarge, coalesce from solitary drusen, and then eventually there's a process where macrophages are recruited, lysozymes are released, and they involute and disappear. And over the course of many, many years, discrete foci of geographic atrophy develop in the place where large pigment epithelial, drusenoid pigment epithelial detachments are. So it's an important finding in the natural history of dry macular degeneration, which obviously is a precursor to wet. And then parafoveal GA, there's lots and lots of subtypes of geographic atrophy: central, parafoveal, confluent, large, and then the autofluorescence subclassifications even more complicated. And we'll look and discuss this next time. But again, important finding. And of course, you know, they're not separate things. This breaches Bruch's membrane. And of course, anything which weakens Bruch's membrane is much more likely to stimulate macular neovascularization. So this is why the natural history and staging is important, because we can stratify their risk. Those early signs, so the 5-year risk, which is a sort of standard AREDS figures, is the risk of getting wet AMD. If you've just got small drusen, it's just 1% over 5 years. If it's stage 2, early drusen, between 63 and 125 microns, then the risk is only 5%. So it's a relatively small increase in risk, but it jumps massively. If it's one eye affected, it's 18% with stage 3, intermediate, more than 125 micron drusen. So that's the size of the vein at the disc. If you've got it in both eyes, it's a 26% risk. And if you've had it in one eye, the second eye risk is 43%. But when you look over 10 years, the risk is really sort of exponentially greater. There's a sort of doubling every decade of the risk of macular degeneration. Sorry, I just need to move this thing out of the way. Even with early features of aging, 15% had stage 3, but late, more established macular degeneration. And with early AMD, the 10-year risk is 1 in 6 will have advanced AMD, and it's huge. 75%, 3 out of 4 patients will have late AMD if one eye is involved by the time 10 years have elapsed. So we'll look a little bit more about the sort of subclassifications. So all these things get divided to the nth degree, and there's sort of classic lumpers and splitters. So you can just say it's wet macular degeneration. And once upon a time, it was really important trying to subclassify. And you can argue that, well, does it really matter these days? Because the treatment's exactly the same. You stick in an anti-VEGF injection and then hope for the best. But there is a value in actual fact, because some subforms respond faster than others. So we'll go through what the basics of these subclassifications are. So they're sort of equally spaced. Type 1 is it's probably a bit commoner than that, actually, but this is from one of the seminal anti-VEGF injection papers. Type 1 is where the neovascularization is under the pigment epithelium. And often, so because the photoreceptors are still in touch with the RPE, patients maintain pretty good vision, but they get distortion. Type 2 is where a very classic of a sort of myopic neovascularization, but in old angiographic terms, these are classic neovascular membranes, and these are occult neovascular membranes for type 1. So type 1 is occult, type 2 is a classic membrane, if you're sort of interested in reading about that classification. But ultimately, they all get the same treatments to start off with. And then type 3 is a RAP lesion. And there's very subgroupings of RAP lesions as well. But primarily, that neovascularization starts in the deep capillary plexus. So the retina has got 3 layers of superficial, intermediate, and deep capillary plexus. And it's a deep vascularization. And of course, the photoreceptors are not vascularized. So these patients end up getting a chorioretinal anastomosis or a retinochoroidal anastomosis from the retina. It then migrates towards the pigment epithelium. And then the later stages end up having a pigment epithelial detachment with it as well. But they do look very different on a scan. And I'll show you some examples. So here's a classic, a typical type 1 neovascular membrane. So we can see here the pigment epithelium rises over this shallow, irregular fibrovascular. So it's solid, so it's not got fluid in it. So fluid is black, which you can see here. There's something else going on there, but the bulk of the lesion is this irregularity. And of course, if there's a pigment epithelial detachment, you can visualize Bruch's membrane. And what's typical of AMD is patients often have quite a thin choroid. So the outer retinal and photoreceptor environment is one of general hypoxia, which is what drives the neovascular process. So when we, someone did request we put on a few OCTAs. Even in the clinic setting, it's sort of make it up as you go along because they are quite hard to interpret. It's when there's a barn door obvious change, you see barn door obvious changes on the OCTA. So what we're really looking for. So that's the OCT here. Can you see my cursor moving? Anyway, I'm pointing things out. Can you see that, or do I need to put the laser pointer on?
Yes,
Bavina?
yes, we can. Yes,
you can
yes.
see it. Yeah. Okay.
Yes.
So in this middle one is the flow. So where we see the yellow speckles, it's flow. So you can see in this little mound, which is elevated, we're seeing flow, and that's just a speckle pattern alone. So what we're looking for is flow, and what the OCTA is ultimately picking up is the movement of red blood cells, corpuscles within that vascular complex. But there's differential flow in these vessels, so it's not completely reliable. But en face, when there's an established neovascular complex, you can see that sort of spider's web or very disorganized spider's web network of blood vessel growth. And you can always tell it's pathological because it's these spirals and loops, and normal blood vessels never coil upon themselves because normal blood vessels filter out in this sort of branching pattern within the plane of the retina. And if it's coiled on itself, always it's pathological. So this is the same patient this was pre-injection, and this patient had 1 injection and it completely dried out. So they do get occasionally really amazing responses to anti-VEGF. So anti-VEGF is primarily to stop vascular endothelial growth factor is a permeability factor, so it causes a blood retinal barrier to break down. So that's what causes leakage, exudation, and fluid. But it also is the primary driver for angiogenesis. So it stops the neovascular complex growing, which is why anti-VEGF works, but it's very short-lived, which is why we need to continue with the medications. So this is a type 2 membrane. So type 2 is where the neovascular complex is between the pigment epithelium and the photoreceptors. So what we said about type 1 is often the visual acuity is reasonably good, but here there's a metabolic block. The new vessels, so we can see here the pigment epithelium is still completely flat against Bruch's membrane. There must be a little bit of irregularity because you can just see Bruch's membrane. The choroid is relatively thin, because it's about 200 microns. The normal choroidal thickness is about 350, 300 to 350, which is typical for an AMD patient. And then there's a bit of subretinal fluid. There's a little bit of shrum, which is subretinal highly reflectile material. It's probably fibrin. A very vigorous leak causes fibrin to lose out. That's the biggest plasma protein. And there's intraretinal cystic changes as well. And then the OCTA is much more dramatic in this case. So you can see that beautiful network of blood vessels. And of course, it's a continuous process. So these blood vessels grow. It's the growing edge, which is the much more denser network. And the feeder vessels tend to be much more sparse. It is a bit like a sort of tree or a bush or an acacia tree. The trunk is there and all the growing leaves and edges are there. And the growing edge is where you see most activity and typically where you see hemorrhage. So again, the flow on the OCTA, because the RP is flat, we see flow in front of the retina. Remembering this is an avascular zone, there should be no blood vessels. If you see that speckled pattern in OCTA there, it's got to be pathological. So type 3 neovascularization, we said, was a RAP lesion. So that's a retinal angiomatous proliferation. So they used to be called RAP. They've changed the terminology into type 3 macular neovascularization. We still call it a RAP in clinical practice. And it's very, very obvious here. So there are stages. And one of the defining characteristics is there's often a little intraretinal hemorrhage for these, and there's lots of intraretinal cystic change. You can see a large serous PED. So the other PED was a fibrovascular PED, so it looked solid. Whereas when we go back to this one, it's very serous. So we can see some sort of anomalous complex coming through here, and then just higher up on the neovascular complex, there's a definite disruption of Bruch's membrane, of the pigment epithelium. So the pigment epithelium is there, becomes very fuzzy there, and then it is continuous again there. And that's almost certainly where the RAP or the neovascular complex has got its retinochoroidal anastomosis. So normally the choroidal circulation is very separate to the retinal circulation. If there's an anastomosis or an artificial join between the two, it's got to be pathological. So on the OCTA on FAS, we can see a little network of vessels just at the top here. There's flow, so flow is white, but it's not so obvious on the speckle or flow characteristics. This is the other eye of the same patient. So we saw, the first day I saw her with that very gross change, we did notice that there was something else going on in the fellow eye. So biology tends to dictate what happens in one eye happens to the other eye as well. So obviously our index of suspicion was pretty high that she's getting a RAP lesion, but she had still good vision and was outside the NICE criteria. But it's a very aggressive thing. She'd obviously lost vision in the other eye. So I ended up bringing her back a week later because she didn't fancy injections to both eyes anyway. And then just a week later, it inflated even more. And then on the OCTA, because this is a very small complex, it's very much with an eye of faith. There's a few little speckles just in that point here. So again, I often say it's like looking at shapes in clouds and trying to make things out. They are quite difficult to interpret, OCT angiograms. We're not quite there yet with how good they are. So type 4 neovascularization it is polypoidal choroidal vasculopathy. And again, the newer terminology is asking us to move away from polypoidal choroidal vasculopathy because histologically, polyps are fleshy outgrowths and not vessels. So you see polyps in guts and that sort of thing. They're asking us not to call them choroidal because it's subretinal. It's not in the choroid. And it's not a vasculopathy, which suggests it's a vascular process. So the new term for a polyp, which again, in clinical practice, we still call it PCV, is aneurysmal type 1, because it most closely resembles neovascularization under the pigment epithelium. Now, the defining characteristic of this is this very, very corrugated appearance. But if you look very closely, you can see a little circle just there. You can see another little circle just here. So these are the polyps or the aneurysms, essentially, what are there. And aneurysms are very ballooned blood vessels, so they're much more volatile and much more likely to bleed. And we see two types of polypoidal vasculopathy. 20% of regular Caucasian patients with AMD will have PCV, and it's a much more aggressive subform. So they're sometimes not so responsive to anti-VEGF, in which case we, certainly at St. Thomas's, we do a lot of supplementary PDT to just get slightly better control of the neovascular complex. But being in Southwest London, sorry, Southeast London, we have a big Black African population. And this is the sort of characteristic presentation of a posterior hemorrhagic disorder, typically in female hypertensive Black patients in their 50s and 60s. It's a posterior hemorrhage. It's a very, very aggressive process. And more often than not, we all do supplementary PDT in those. So there is some value in subclassifying these. And if you get a suboptimal response, changing tack and early intervention rather than just plodding on and on and on with injections, deciding it's not working when the vision's dropped. So we try and be as interventional, and sort of an accurate phenotype, an accurate diagnosis always works well, because then you sort of expect the result. So OCTAs aren't good at polyps because the flow is not very high. We can still see a few of the polyps here, but on a conventional angiogram, so this is an ICG. The ICG is the best way of looking at PCV. And there's often the polyps, but there's often a little branching network of vessels as well. So once upon a time, we did try lasering these with hot laser. You wouldn't do it here because it's under the fovea, but that just didn't work because they would just pop up elsewhere, because the entire complex is much, much bigger. Now, this is another example, and polyps can be varying in their phenotype. They can be solitary, they can be multiple, they can be the cluster of grapes like I just showed. But very typically in the Black African patients, it takes this peripapillary form. So at the top here, we see this little double hump, but within it, there's a circle. So you always look, and it's much easier to spot these when you're scrolling through. I'm sort of hoping you can see that. I'm not just making it up, but within the elevation, there's a very discrete little circular change. When we look further down, it's a bit more of that corrugated appearance, and there's some chronic leak because there's an exudates here. And then further down is a bit more aggressive. The retina is quite swollen. There's some intraretinal cystic change. There's a serous component as well. So there's often multiple lesion components. So there's the polyps, there's a branching network, there's the standard fibrovascular pigment epithelial detachment, there's a serous pigment epithelial detachment, there's a sort of full house of changes. But again, the ICG is much more sort of defining that there's a big network of abnormal blood vessels. You can see how different they look. They sort of jump out, and it's you really got, when we do PDT, we really try and address the entire lesion complex rather than just the polyps themselves, which really doesn't do anything of any great value. And then the end stage is subretinal fibrosis. We don't see this very often, but just last week someone came through, left eye, non-dominant eye, completely ignored. They may be in a bit of amblyopia, so patients end up presenting very, very late, and that's really not what we want to see. And OCT scans in an end stage subretinal fibrosis looks just very, very disorganized. So the normal retinal architecture is just completely destroyed. You can't really recognize anything. It's just a big sort of fibrogliotic mass, and no treatment's really going to work for that because the nerve tissue is completely destroyed. So we used to see that a lot. We used to call it a disciform scar, but now the preferred term is subretinal fibrosis. So at the beginning, I sort of slightly cheekily put all those cases, which none of which were wet AMD, but they were all seen in clinic. So the thing is always to consider alternative diagnosis, because the key is not all fluid and hemorrhage with subretinal RPE changes is wet AMD. There's plenty of other conditions that masquerade. The retina can't do that many things, either gets new vessels, it either scars, either becomes atrophic, but it's all that pattern recognition as to what points you in the right direction. So so here's in the little quiz we did at the beginning, it was the first case. Of course, there's little bumps which look like drusen, and there's subretinal fluid. So it's not unreasonable to say, well, there's drusen and subretinal fluid, but so it must be wet AMD. But of course, this is a 12-year-old child, so 12-year-old children, because the definition of AMD is age-related, and the age has got to be 55. But of course, we see this in older people as well. If we look at the Optos image, we can see a discrete abnormality. There's a little whitish opacity there. The autofluorescence, an absolute giveaway. So this is Best's disease. Of course, it's rare and genetic and what have you. But of course, these patients grow older, and we've got 2 or 3 Best disease patients, because the late stage do end up getting neovascularization. So if there's a sudden change, we would inject these patients. But again, it's just to highlight there's other things. So this was a 32-year-old lady. So of course, by definition, with early onset drusen, so she had drusen and subretinal fluid. This is Doyne's honeycomb dystrophy. Have these very characteristic little streaks and lines. And the sort of absolute key thing is there's drusen at the disc and drusen nasal to the disc as well. And she had a positive family history. And these patients get fluid, and it's absolutely impossible to tell whether it's neovascular or not. Essentially, this is just a metabolic block. Normally, fluid flows from the vitreous towards the choroid. And if you've got a great big subretinal scar, of course, it's going to be impermeable to fluid. So it sort of acts like a little bit of water repellent plastic or Gore-Tex or something. It just bounces fluid straight off. So sometimes if these patients get worse, we would just try an empiric course of anti-VEGF, because angiography just doesn't work in these cases. So that's what her color picture looked like. Of course, she's got drusen, she's got fluid. It's not unreasonable to assume there's some neovascularization going on, but it isn't age-related neovascularization. This is what we mean by drusen at the disc. These patients with Doyne's typically have drusen at the disc and a few drusen nasal to the disc as well. In the angiogram, you see these little linear streaks radiating out. So that's a genetic entity. Now, this is much more common. This is an adult vitelliform. Now, adult vitelliform can be primary or secondary. So you can get it secondary to vitreomacular traction. You can get it secondary to basal laminar drusen. So this was a younger patient, still in her 50s or late 40s when we originally saw her. And it's quite common for patients with basal laminar drusen, which are another early onset drusen disorder, to get these little lumps of fluid. And of course, the assumption is, and we've seen quite a few of these cases, where they've had injection, of course, no response because there's no neovascularization. And then the penny eventually drops. But of course, we're always looking out for the clues. Is it early? Is it behaving in the way it should be? And sometimes very, very difficult to say. And of course, there's a big overlap between adult vitelliform and juvenile vitelliform, which is Best's disease, because ultimately there's a central lesion, which looks the same. There's lipofuscin, which is deposited, but and there's possibly a genetic overlap as well. Polymorphic changes in the same gene which cause Best's disease are associated with vitelliform macular dystrophy. And then the autofluorescence isn't so striking, but there is an increased autofluorescence signal. It should always be darker in the middle. And we just sit on that because there's a natural process where these things appear and eventually involute as well, which may end up resulting in atrophy. So again, this patient is a sub-RPE irregularity with some fluid. So again, reasonable assumption. It looks like a little bit of a myopic fundus. But again, when we do a vertical scan, it's always important to do a vertical and horizontal scan in high myope patients. So this is a dome-shaped maculopathy. And again, we see this time and time again coming through for second opinions where they've been injected elsewhere, and then they come through for a lack of response. And people say, oh, is it CSR? But of course, myopes very, very, very rarely get CSR. But there's often this little sub-RPE elevation as well. And these are angiographically completely inert. So when we do a fluorescein angiogram, nothing leaks. So if they're angiographically inactive, they can't have neovascularization, because neovascularization is in immature blood vessels, and immature blood vessels are always incompetent and they leak, which is why we still do fluorescein angiography on occasion. The OCT has not completely replaced it. So again, very myopic appearance. And then this last case, which looks very, very, very much like AMD, with widespread RPE changes, but those RPE changes are all around the disc. There are things that look like drusenoid PEDs and serous drusen. There's pigment epithelial irregularities, there's fluid, but this patient's got a super thick choroid. So this is peripapillary pachychoroid changes. So this is CSR in actual fact. So still, even though classically it's older patients who get CSR, of course, older patients do get, it's classically young patients get CSR, for hypermetropic men in their 30s, 40s, and early 50s. But of course, we still get 80-year-olds coming through, because you can never say never for any disease. And then how we really decide someone's got pachychoroid spectrum disease is a dysfunctional choroid. This is called a intervortex anastomosis. Vortex vein from the top is communicating with a vortex vein at the bottom. These are watershed. The vortex vein should never be dilated in the middle, so we immediately know it's pathological. And this is all part of the pachychoroid spectrum. And that autofluorescence signal is very, very anomalous. You don't get AMD looking like that, not stellate in that way, and you don't, because drusen don't autofluoresce. Age-related drusen don't autofluoresce. If they autofluoresce, it's got to be something else. And then
sorry, Mr. Mohamed, I
yeah.
just wanted to let you know it's 10 to 8.
Oh, okay, yeah,
Okay.
yeah. So I am on the masquerade thing. So
Okay,
and then we
perfect.
started 5. I should be done in about 5 minutes. I'll start going a little bit faster.
Thank
Yeah.
you.
And then so this is another version of the same thing. So when peripapillary pachychoroid changes, again, this was patients sent through to us as wet AMD. Of course, it does look like wet AMD, lots of pigmentary changes, lots of intraretinal cystic change, but again, a thickened choroid. And the patient was younger. This patient was in their 40s and in chronic steroids for renal disease. And then angiographically, that'll be completely inert, because this is just a disintegration of the retina from chronic disease. So the retina just breaks apart and loses its architecture for whatever reason. Now, new vessels can grow. So we've mentioned the pachychoroid spectrum before, and we now look at specifically OCT, the choroidal detail. And of course, again, this was a lady who's in her 70s and has got new vessel growth as a result of chronic CSR. So she's atypical because she's a woman and she's old, but it still happens. And of course, if you've got established new vessel growth, anti-VEGF works sometimes, not always, but these patients do very, very well with PDT. The process gets switched off. And again, I have a particular interest in CSR, so we get lots and lots of these patients coming through to our clinic for second opinions. Of course, the cure, PDT is curative rather than anti-VEGF, which will do nothing, because VEGF is not massively upregulated in these conditions. And then the OCTA shows in pachychoroid neovasculopathy, it's a very slow growing, mature complex. So you see these things. So adult vitelliform, again, very, very common thing. We've already mentioned one case as a secondary form. You can get it primary or secondary. And this is a slow process that undergoes an evolution. They develop slowly over 2 or 3 years, where you've got this lipofuscin or waste material, which autofluoresces, and then eventually it liquefies. So again, it's another patient who repeatedly come up in clinic, who've had injections and get a suboptimal response. That waste material will liquefy, and then it looks like subretinal fluid, like in this case. Now, this is a secondary vitelliform because there was a VMT as well, because there's a little bit of a tractional lamellar hole there as well. But that, of course, is fluid in the subretinal space, but it's semantics as to whether you call it subretinal fluid. That's a cavity. It's a localized, and angiographically, that would be completely inert. It wouldn't show any leakage at all. It may stain, but it won't leak, and there's a difference. Now, myopic CNV, another sort of condition, they behave very differently in terms of treatment. And whilst this is obvious, because there's a great big lump, and there's a complex, and there's subretinal fluid, more often than not, they just have this thing called a fuzzy border. So this is a patient I saw very recently, and you can just see this disruption. So there's no subretinal fluid, there's no intraretinal fluid, and this type of change is very, very destructive. So it's again, this patient who was seen was told, I'm not quite sure why, but she was told that she had CSR and it would just go away by itself. Myopic females don't get CSR. Myopes don't get CSR. CSR has a thick choroid. This is an extremely thin choroid. So this is a sign you've really got to be able to recognize these pathological myopes when they've got this outer retinal disruption, which just is this, well, it's a pretty good description, but the literature called it a fuzzy border. When you see that, just suspect neovascularization. And again, sometimes you can get caught out because not all neovascularization is myopic neovascularization. Sometimes it can be inflammatory. So myopes can have PIC, punctate inner choroidopathy, and then those patients will not respond to anti-VEGF alone. So again, you've got to have the ears pricked up and looking out for other changes. These multifocal lesions are very, very typical of PIC, and then new lesions will develop, and they settle down with steroids in addition to their anti-VEGF agents. I'll skip over that one. MACTEL is another thing that comes through, macular telangiectasia or juxtafoveal telangiectasia. But the thing to remember here is when neovascularization happens, something is leaking, so we'll elevate the retina. But if you see here, the retina isn't lifted, there's something lost, and there's cavitation. So it looks like fluid, but it's really just the retinal tissue which is disintegrated on itself. But the key here is the retina is still flat and still has its relatively normal profile. These patients end up getting intraretinal pigment migration. And there's a few cases where there's fluid without activity. I am very much coming to the end here. You'll often see over areas of geographic atrophy, intraretinal cysts, because the pigment epithelium is not there. The pigment epithelium is a pump for pushing fluid out. So you get pump failure. Similarly, chronic scars of tubulations, which look like fluid, but aren't fluid. They're just a feature of chronicity. And then pigment epithelial detachments sometimes have little shoulders. There's a draping effect. The retina it takes the shortest course. So obviously it'll take a chord. So when you have a very steep pigment epithelial detachment, it'll look like there's a bit of fluid, but that's just it's draping down from the peak down to the base. So it's taking the shortest course, and that will of course be angiographically inert. We have to be absolutely certain in a clinic setting. And then sometimes with over these little pigment epithelial detachments, you get pump failure because of this pigment migration. So little pockets of fluid accumulate. And you can see why the retina is just draping between these. So of course, there's a little bit of fluid in the middle there. And similarly, if there's a rip of the pigment epithelium, you can see a little atrophic patch. If there's no pigment epithelium, of course, you're going to get fluid because there's no pumping mechanism. I'll skip over that one. Right. So I think what we want to just say is whenever you suspect someone of having wet AMD, look in the other eye, make sure there is dry AMD over the age of 55, drusen, pigmentary irregularities, typically high-risk drusen, but you can get neovascularization with small drusen as well. And then always think, is it something else? But the bottom line is these patients always need referring in because most macular neovascularization will respond to anti-VEGF injections. And I suppose it's up to the clinic to make sure it's not a masquerade syndrome, but for your own sort of professional satisfaction, always think, is it something else? So I'll stop there. And these are the questions that Bhavina brought up. So I'll leave Bhavina to discuss whichever she wants to.
Thank you so much. That was amazing. I learned so much. So I'm hoping that others also felt the same. There was one question in the chat when it was just, I guess, I'm inferring based on the conversations that you had that PDT is available again. I think.
It is. It's not a completely unlimited, but I mean, I keep getting told by Novartis, who's the distributor, we do more PDTs than anyone else in the UK at St Thomas's, and I run that PDT clinic. So we accumulated, typically we were doing about 100 PDTs a year. We accumulated about 120 patients on the waiting list because we stopped asking people to refer. We've just cleared that backlog, so we're getting access, but it's not completely unlimited access yet. But it is there, it is available. So, anyone who's got bilateral disease, polyps which aren't responding, we're zapping away. Yeah, and we get really, and the delay hasn't really caused suboptimal responses either. So people are responding and they are settling down with PDT.
Nice, lovely. Thank you so much. In terms of these questions, these was my interpretation of what may be wanted to share knowledge with. The red flags you've gone through very nicely. Thank you very much. How to refer into hospital for what we suspect is wet AMD. I'm hoping that our referral guidance that went out to all our practitioners and is available on our website is clear about it, but I'll just run through it with Mr. Mohamed as well. In terms of wet AMD, it is an urgent referral. We do want to get them vetted and seen by the hospital department as soon as they can practically see them. When we are referring into St Thomas's, you can either refer, if you are a MEX practice, into ERS, and we will triage it and expedite the referral into hospital. If you are not a MEX practice, you can send that referral to the single point of access via the email. We do recommend that you provide as much information as possible. So your referral letter, any scans and images, if you have them, that is absolutely beneficial to helping that triage system work efficiently. So please do that. At King's, the referrals go from Denmark Hill to the email, and for Queen Mary's goes again via ERS into the RAS system. How and when will the patient be contacted? Ideally, they're contacted as soon as we can guarantee an appointment. At St Thomas's, we aim to try and get their seen, within the next available appointment, and they are contacted by the admin team at the single point of access to confirm an appointment. The email system, King's at Denmark Hill, will contact the patient within a week to 2 weeks. And again, likewise with the RAS for Queen Mary's. What happens if the patient doesn't hear? I'm just answering these questions on your behalf, Mr. Mohamed, by the way.
Yeah, well, it's different in every hospital, isn't it? So, I
Yes.
mean, I would say if someone hasn't heard in 7 to 10 days, they contact eye casualty. I know
Mm,
our eye casualty has said don't send them to eye casualty, but early intervention, you always get the best outcomes. Delayed treatment always causes suboptimal responses. So, the nice guidance is a 2-week window. That's sort of generous.
mm,
Ideally, anyone who comes into, I mean, most of us at St Thomas's, I mean, we have a vetting rota. They come
mhm,
into our Epic outbox. So or it either comes by email from the secretaries or it comes into our vetting. We've got a rota. Someone checks every day. And in the medical retina service, actually, we never have more than 1 or 2 patients waiting for vetting. So they do get looked at.
mm.
Whether and I
Amazing.
think we're generally pretty good with responding to patients, and we're, we're generally pretty good at just absorbing extra patients.
Mm.
And when they come
That
through
doesn't mean
casualty,
everyone needs to go to St Thomas's.
no, no, please don't send everyone St Thomas's. But anyone coming through the eye casualty at St Thomas's, most people will get the injection on the day.
Yes. Yes.
But don't send all your patients to St Thomas's, your local hospital, please.
So that leads on to the next question, the last question on this presentation. What should the patient expect to happen at the hospital? So we have referred them in, we've got an appointment for them, they've got an appointment. What do we tell our patients that is likely to go through, what happen?
So when they come to clinic, obviously the usual vision dilates. Everyone by default in the medical retina clinic gets an OCT scan and then an OCTA if there's any diagnostic dilemma. But for the vast majority, probably 90% plus, we will just make that diagnosis on the OCT alone, which is the purpose of this, So if there's increased awareness of what we're looking for and you're looking for the same sort of thing, we have a high confidence. And if there's a diagnostic dilemma, or if there's any sort of remote uncertainty, if it's very early disease, doesn't quite meet the criteria, if the patient's slightly reluctant, we'd sometimes bring the patient back a few days later or a week later or so, but never more than that because it's such a volatile condition. And one hemorrhage and it's sort of game over. So the early interventions always you get the best outcomes. So as soon as we're one-stop shop in St Thomas's, so if they're coming for the first time, then we'll go through the consent process. We're supposed to be giving patients choice of which injection agents we use, but the reality is it's a toss-up between Eylea or faricimab. There's some sort of nuances as to which one we use, and now we've got sort of high-dose Eylea, but we've not got free unfettered access to that yet. There is a role for it, but most patients will respond very well. The vast majority of patients are very well controlled on standard conventional anti-VEGF. But of course, there's always going to be better. And we tell them there's a loading phase, so there'll be an injection a month, and individual responses are slightly variable. But our faricimab outcomes have been stunningly good. So a lot of patients, not quite clinical trial data, because the clinical trial treatment and retreatment criteria is slightly different to what we do in clinical practice. Clinical trials are a little more tolerant of disease activity before retreating, because they're trying to make their product look better than it actually is. Whereas we're much more rigid about chasing every little bit of fluid and trying to get the OCT scan as stable or as inactive as possible. As form and function go together, I think I would not, the retina in its normal homeostasis does not have fluid. So for the drugs to say, well, you're allowed to tolerate a little bit of fluid, in the long term, it's always harmful.
I've thought of another question. I apologize that I'm throwing it at you. But it's, say, for example, a patient is under the hospital, is having regular treatments, and then there's a delay in their appointment. What do we advise that person?
Well, we tell all our patients at St Thomas's to contact our eye casualty. If they're a St Thomas's patient who's getting regular injections, we tell them that their second eye, if it's one eye only, about 20% of our patients are on bilateral injections. So that's quite a high percentage. A lot of patients have been going for a long time. So we always tell them to look out for second eye involvement. The ARMD study is 42% over 5 years. Other trials have suggested somewhere close to 50 and 60%, because the AREDS was pre-OCT in actual fact. So we tell our patients, if you haven't heard, but there is today, there's staffing issues, there's all sorts of, since Epic, which is a sort of unmitigated disaster, that has reduced our capacity, our ability to, because we're just doing that much more admin, it just impacts on how many patients we're getting through. But we do try and most patients aren't delayed by about a week or so, but we tell patients, if your appointment hasn't come through, just phone through they are given a little slip with the clinic hospital, the phone number for the clinic and the eye casualty number. So yeah, we don't want patients not coming through. But of course, patients get delayed for they're elderly, other illnesses, or the relative can't bring them that day, and various things, life events do get in the way occasionally. But we tell all our patients to contact eye casualty. That's really important. Otherwise, it's a hugely expensive treatment, and a delay of 2 weeks can completely unravel all the hugely expensive treatment and whatever control you've achieved.
Yes, excellent. Thank you so much. I'm aware that we have just now gone over time. For all of our participants, if you have any questions, please do take yourself off mute. You are all on mute at the moment. Please take yourself off mute, ask questions. You're more than welcome to type it in the chat. While I'll give everybody a few moments for that. And obviously, if you have to run from the timing wise, then please do. We're very pleased that you joined us for this evening. While anyone is thinking about questions and possibly wanting to type it in the chat, can I just show you a couple of slides for you to look at today? Oh, yep, perfect. Is it okay if I ask you to stop sharing for a moment?
Yep.
Thank you.
And of course, anyone needs to go, they need to go. So can you share? Can you share now?
Yes, I think so. Can you see my slide now?
Yeah.
Lovely. So, oh, hold on, let me slip by. So this was the referral. This is an old referral, so I'm actually cheating a little bit, but I just wanted your interpretation of the OCT. So born in 1940, so this patient is in their 70s? I can't count. 80s.
84.
84. Terrible maths, that is. Bizarrely, the vision is noted down as 6.6 and N5, whereas previously there was 6.75 and 6.6. So it looks like they've improved by a line in their right eye.
Amazing. Must have had photobiomodulation.
It's amazing.
Okay.
Their OCT shows drusen and PEDs in and around the macula of both eyes. It's difficult to rule out early subretinal fluid. The patient reports metamorphopsia on Amsler in the left eye.
And we all know Amsler is not great.
No, no. Unfortunately, it is also one of the things that we were required from the ICB's point of view. They do want us to be checking on AMSLs. But there you go. There is raised area temporal to the optic nerve, which was not there in previous scans. Ocular health is normal. Please refer urgently to rule out wet AMD. So these are the fundus images. So this referral actually was very useful in that they did provide all of the scans and images, which is very helpful. So these are the images. This was the scan of the right eye. Is it okay if I let you go through that? What's your opinion
Oh,
on?
me? Yeah. Well, based on what we've gone through today, that's a beautiful scan, isn't it? So the foveal dip is intact. Well, the thing that jumps out is obviously there's large drusen, there's small drusen as well, probably some intermediate. The choroid is slightly thinned. The anatomy of the choroid, it's not completely normal. But otherwise, the rest of the retinal architecture doesn't look so bad in there. There's probably some general thinning. It's probably a little bit. It's a wide OCT, isn't it? So um,
Yeah, yeah.
so
And then
swept
the
source OCT.
yeah, this
Um,
is the
uh,
left eye.
yeah. So again, if the patient's describing metamorphopsia, um, if they described it centrally, I mean, the one thing to say is a vision 6/6, so they're outside nice treatment guidance. But the Royal College of Ophthalmologists says something different that you can treat, and I think um, our local boroughs tell us that we are allowed to treat patients even if they're outside nice guidance in terms of visual acuity. So the obvious thing is just that bump next to, oh, you've got the controls. So just
Oh,
point out
sorry.
that bump.
This bit.
Yeah, so they're drusen,
Mm.
and there's a disruption of the.
Sorry, hold on. I went
Oop,
past. Yep, there you go. Yep.
yeah, and
This
then
bit.
if you, yeah, so that's drusen. There's a little bit of a disruption of the ellipsoid line. There's a bit of
Mhm.
corrugation as well, so the patient will get subtle metamorphopsia. There's probably a little bit of an epiretinal membrane, but the obvious thing is next to the disc. There's a Yeah,
Yes, this.
so it's just under the retina. So the papillomacular bundle, the nerve fiber layer, has been displaced. That's probably why the patient is getting symptoms out of keeping with the size of that, because that should be at the edge of the AMSA grid, because that's how the physiological blind spot. But
Mhm.
there's a bump, and that, from what we said earlier on, when you see a bump, it's difficult to say exactly which layers are. Sometimes you
Mm.
need to scroll through these images to really try and work out
Yes.
what's elevated or not. But based on the picture that there was a, just go back to the color picture again. There was a,
If I can, hold on. Got to press the right buttons. There you go.
yeah, there we go. So just point, there's a little,
This bit.
what looks like a little hemorrhage. Yeah. So,
Mm.
the suspicion would be it's either a peripapillary neovascular membrane, but much more likely that it's a PCV or a AT1 lesion. So polypoidal vasculopathy would be my number one concern for this.
Mhm.
Because PCV is volatile, aggressive, and potentially hemorrhagic, I would say that patient needs to be treated. Now,
Mm.
there's different schools of thought. Some people will say, well, it's not leaking yet, and there's no subretinal fluid, but the size of the lesion in this case is
Mhm.
big. Sometimes we'll do an ICG video angiogram on these patients, and if there's
Mhm.
pulsatility on the video ICG,
Mhm.
that tells us that lesion is much more likely to leak or bleed. So we have a low threshold. But strictly from the NICE criteria, there's a
Mhm.
lesion which isn't, the vision's too good.
Mhm.
The lesion and its consequences aren't involving the foveal center. So you
Mhm.
can watch that. My worry is that's a volatile lesion and we're much more inclined to treat. So again, depends on what the patient wants to do. They might not be so inclined to have treatment, but patients like this, we'd probably try and persuade that we will do something, because if they bleed, then it's too late. But
Mhm.
the PCV, 85% will settle with injection monotherapy.
Mhm.
1 in 6 will end up needing supplementary PDT. That's small, it's isolated, single polyp. It's not like it's a massive network.
Mhm.
So the chances of keeping that eye stable are pretty good. But it's a difficult one. It's a good case to discuss because, say, they're sort of outside the normal guidance.
Yeah,
So
yeah.
is it wet macular degeneration? No, it's not.
No.
But because there's no obvious type 1 or type 2 neovascularization. So PCV you can have as part of a neovascular. Oh, can you clarify what ICG is? ICG is indocyanine and green angiography. So we do there's different types of angiography that's looking at the circulation at the back of the eye. Fluorescein angiography is very good for the retinal vasculature and the RPE, but for looking at any choroidal pathology, so all the pachychoroid spectrum, PCV, and macular neovascularization, we do ICG angiography. So most of the angiograms I run will look at the superficial and deep vessels, and we almost always do ICG and fluorescein angiography. So ICG is indocyanine and green. It's a much better way of looking at deeper pathology, essential for CSR, essential for polyps or AT1. And actually, you can only really diagnose polypoidal on ICG.
Yeah, thank you. So then one last question on this one, and then I've got a rather interesting one I wanted to show you after this. How soon should we be seeing this in the clinic? So
this patient
then by wet AMD pathway, so it would have gone through the 2-week pathway, but is that the correct urgency?
I would think so. I'd say this is something that needs dealing with. I would not be if this was my eye, I wouldn't be comfortable having that in it.
Yeah. Thank you. Okay, so the next one I wanted to show you was a rather interesting gentleman that I saw, 83-year-old gentleman. He attended for a routine eye examination. He has no concerns. He was diagnosed with adult vitelliform in the 1990s and was therefore discharged from the hospital for routine reviews at his opticians.
So quite young for adult vitelliform. Okay, I mean we get it sort of 50s onwards, I suppose. Yeah, 30 years ago. Okay. Yep.
In terms of his medical history, he's actually a very fit 83-year-old. I want to be that fit when I'm 83, I have to say. But he has had a history of Guillain-Barré, so that's the only sort of notable history. His VA is 676 in the right eye with N5 at near, 66 in the left, N5. He's a low hyperope, he's a compound hyperope. Nothing major going on there. I've got some videos. Is that okay?
Yeah. And
So
everyone else is fairly happy continuing for a short while. Yeah. Yeah. It shows a video. So that's
okay.
2023.
2023, this is a right eye. It
Okay,
goes
so
rather rapidly.
yeah, there's not much AMD.
No,
We're expecting a bump anytime now. Yeah, okay, that's very typical. So that is, it looks typical of a vitelliform. And yeah, if you can you drag it back to there?
yeah, a little
So
bit.
adult vitelliform can be hugely variable in its size. It's a process where it forms and it starts off as solid, it then liquefies, and then eventually the average is about 8 to 10 years for the process. So then it liquefies, and then it eventually, in most patients, will leave a central atrophic spot. I'm surprised that the vision's that good with that central lesion, because you'd think so there must be some sort of good eccentric.
Well, I mean, that was 2 years ago.
Yeah.
This is this year, and there has been some development in this lesion. And the question is this normal development? So let me just play the video.
Well, so from what we've said, we do expect it to change.
I'll show you the actual
screen
again.
There's some pigment migration in there. So often with adult vitelliform, there's a little sub RPE change as well. So there's often some RPE dysfunction, which is why you then accumulate lipofuscin. So there's some abnormality in the visual cycle. So that debris is accumulated at the very center. This looks like, I mean, there is an epiretinal membrane. It doesn't look like there's any VMT, which is a sort of secondary vitelliform type thing. But more often than not, there are a few little RPE elevations within, and any RPE elevation or pigment epithelial detachment eventually gets pigment migration, then pigment liberation, and often very chronic AVMDs will have a little hot cross bun sign, a little cross or a little stellate pattern or a little solitary focus. and that is pigment migration. So Muller cells are taking up pigment. So
Yeah.
that's just a feature of chronicity.
Yes.
Yeah,
Yes.
so it's
Then
consistent with
lovely.
a very small AVMD. So the patient's lucky that it's not a great big whopping thing, because sometimes they're sort of a couple of disc diameters across. Very typically, they're sort of half to one disc diameter. So that's a sort of third of a disc diameter, quite small localized lesion. And the rest of the retinal architecture looks pretty good, which is why the vision's good. There's not much
Yeah.
AMD. There's not
No.
much AMD. So
There is far more migration in this one. Oh, hold on, let's turn this
oh, this
on.
is a fellow eye.
Yes, this is the fellow eye. So this is the one that he's um, quite happy with the
Oh,
vision.
okay, yeah.
He's
And
actually better in the VA in this one.
you can see that it goes off in an angle, and it
Yes,
goes off in an angle because the pigment is following Henle's layer, which is all disrupt. So it goes off at the center in
yes,
that acute way because the pigment is following. So it tells us that there's cellular death going on. So the melanosomes should be in the pigment epithelium.
yes.
They're lost, they die, the pigment epithelium loses its integrity. And
Mhm.
then Muller cells have got a sort of phagocytic role as well, where they
Yes.
pull up debris. And
Clear it
then
up. Yeah.
so in this one, there's not much liquefaction. It's amazing how much you can see just from a single scan.
Yeah.
But there's a little bit of RP elevation. So there's a little
Yeah.
pigment epithelial detachment. There's some
Yeah.
solid stuff as well. And then that was 2023. Now okay. So this one is stabilizing out by
Yes.
itself. Yeah.
I'll
Uh,
go back to the video to here. Here we go.
Yeah, so there's a few little sort of RP elevations and things. So there's a little bit of subretinal deposit there as well. And the bright white stuff is pigment migration. So
Yes.
there's a little chronic, tiny pigment epithelial detachment, pigment migration, pigment liberation. It's part of the process. So they form, they accumulate, they liquefy, they dry up, they become atrophic. And when
Mm.
they start going into that atrophic stage, that's when
Mm.
you sort of see the pigment. And amazingly, some people just survive the whole episode. A small subset still maintain good vision. Most
Mhm.
people end up dropping when it's in sort of 10 years plus to about the sort of 624
Mm.
mark. But there's rarely catastrophic loss of vision with an adult vitelliform.
So would you expect, I mean, considering he was diagnosed in the 1990s and he's been pretty stable vision-wise, OCTs, we've only had access to OCTs, in the latter few decade or so. Um, would you expect to start seeing these changes now, given it's sort of 3 decades on?
Well,
Would we have expected to see
yeah,
it earlier?
it
Or there's
doesn't.
no rule with it?
No, the general rule is it's a sort of 8 to 10 year span, but
Mm.
we're never surprised by anything anymore because, um, you know,
Humans.
yeah, there's so much variation, but that is very consistent with just a small adult vitelliform lesion. It's not
Mm.
really anything else that can look like that.
No,
Yeah.
no. Yeah, amazing. Thank you so much for
So the
letting me
thing to look out
share.
for, we do get the occasional patient. We've had a couple in the last year who have
Mm,
then ended because the outer blood retinal barrier is disrupted.
mm,
The inner blood retinal barrier is the retinal vasculature. The outer blood retinal barrier is the pigment epithelium. Because that's disrupted and Brooks membrane is bare,
mm,
there is still a risk of secondary neovascularization. So we tell the
mm,
patient still that if you notice any acute worsening of vision,
mm.
then get in contact ASAP.
Yeah,
Yeah.
yeah, amazing. So I'll stop sharing. Now I can finally see the chat again, which I don't know if there was any more questions or anything. No, just thank yous. Okay, amazing. Right. Thank you everyone for staying a little bit longer. I did try to
Yep.
keep it more to time.
Sorry,
We're
guilty
very
again, but
We're very
oh,
grateful to
still
you, Mr. Mohammed, for all of your teaching. It was amazing and really useful. So thank you
okay.
very, very much.
Okay.
If you have any other questions, participants, then please do get in touch. You can email in and ask questions. And please do, if you have interesting cases that you would just like Mr. Mohammed's opinion on, then please do send it through and we can take it through. Our next event is on the 27th of March, and the topic will be on dry AMD and RPE level disease. So please join us on
Yeah.
that event.
So I might just keep it to dry AMD because
Okay.
RP disease is huge.
Okay.
Or it could be very little. But if we cover the sort of common things, and I think photobiomodulation is such a hot topic at the moment.
Yes.
Not for me, it isn't. I just say it's
No.
rubbish. It's
Yes.
it's rubbish. Don't do it. But we'll say why it's
Yes.
rubbish
I
at the
think
moment.
if we
Yeah.
have patients that are asking questions, or certainly we want to give the patients all of the information, then it's useful to know the good and the bad,
Yeah.
and discuss it.
And
Yeah.
then okay, so I'll try and get a few more cases like this. And who knows? Next time I might stick to time.
Thank you so much.
I
I'm
tried today.
grateful. I'm grateful for everything you teach. So thank you
Great.
so much.
Okay.
I'd like
Thanks,
to wish
then.
everyone else a good evening. Enjoy your evening, and we will see you next time, hopefully. Good evening.
All right.
Bye.
Bye. Bye. Bye, Tanya. See you tomorrow.